is a two-dimensional imaging, which means X-rays are taken, the dye is injected. Once you inject dye, these arteries will be visible by X-ray, otherwise it won't be visible. So we do one thing, we take X-rays from this angle, we move the machine to other angle, take X-rays from this angle and from this angle.
3D.
Sometimes, particularly when the artery divides in two branches, because of the angulation, we have a chance of missing a block in the beginning of the bifurcation where it divides.
Yes.
So X-rays, because we have to take in different angles.
Both three.
So this is a two-dimensional imaging angiogram. So we have done angiogram. In angiogram, in the left main LED area, that block was not clearly seen. So what we have done is, we have done another advanced imaging, which is OCT. OCT is optical coherence tomography, where with one injection of dye, we can get a complete three-dimensional view of the artery. It's a three-dimensional view. So the one big thing is OCT is actually we send a small something like a camera where it emits infrared light, and the light we can see the blood vessel, the magnification of almost like an electron microscope. It is so high magnification we can see. But the OCT, the problem is the light will not pass through blood. So when you have the blood going into the blood vessel, we cannot see the structure. So we have to remove the blood. So how do we remove the blood? We inject dye, and for the few seconds when we inject dye, 3 seconds, at that time quickly we image. So the blood is not there, the dye, what is we are giving the contrast dye, that will allow the light to pass. So in that 3 seconds, we get a complete imaging. That is OCT. So now I'm going to show you the OCT. So if you look at the OCT, so what we have done is, we have in the 3 seconds, we inject dye, and quickly that one run it will take completely. So now we have done already, and now what I am going to show is, I am going to show you, this is the, I am going from the front beginning end. So if you look at, this is the left main. The left main is quite big. See the left main? It's quite big. We can see it clearly. This is the left main. This is the catheter which I am passing. So I am going from the left main. This is a cross section. This is a longitudinal section. The artery is like this. Wherever I move, that cut area will come here. So if you can see, I am moving this. So every area we are seeing the cut section in this. So this is looking big. The artery, the diameter is big. There is no block. You can see that I am moving from the left main. I am going inside the artery. See, left main is looking good. No problem in the left main. You can see the artery is big. But as I go more and more, we are coming now. Now we are coming to the distal part of the left main, and you will get the circumflex branch now. See, you can see the branch. You can see that it's opening here, the branch. And now, as I am going into the LED, you see it's very tight. And you see the area, the lumen. This is the lumen. Lumen means the blood vessel area. It automatically measures. It says 2.3 millimeters square. So if you look at the left main here, you see the lumen is 12 millimeters square.
Bigger.
It's very large. So, but as I move more and more closer, it is the left main, the LED. This is the LED. It comes to 2.12. It further goes down 1.99, 1.96. 1.82 is the smallest I measured. See, this area, it's 1.82 millimeters square.
Smallest.
It's very tight. Can you see that? The area is very small. Now I'm moving further to see how long the block is. This you can see here also. This is large and here it is narrow. Here in the longitudinal view you can see it. So as we are moving more and more. See, the area is increasing, but you see, but then it comes to beginning 5, 6, 7, 8, 10, 11, 12. Here you get again big one. You see, the again big, 10 and 12. See, 12 here.
So it means the actual lumen is 12.
For him,
it has come to, that particular point is coming to 1.8.
This area is 12. For him, this artery is little big. By nature,
Longer.
it is bigger diameter.
Okay.
So the area is quite big here.
Okay.
So the problem is, this area is so tight, so the blood is not able to pass through. So this is like again like an angiogram. It's a photo. It's not telling the flow. It's only telling that there is a narrowing there. Angiogram didn't pick it up because angiogram was a two-dimensional picture, and in an area where it divides, the angulation was not good enough to pick it up.
What is the percentage of that particular, like this, doctor, as an angiogram not picking it up? Generally,
the sensitivity, specificity is around close to around 60 to 70%. Not that's all. It is not very high sensitivity specificity.
Okay.
So it definitely low. This one, the advantage of this one, it is you can rotate it. For example, if I move area, I can see three-dimensional. See this? As I am moving, I can see the entire three-dimensional view of this. So the entire artery, I can look at it, that it's moving. And the second, with one injection, automatically it gives measurements of every area. It gives you automatic measurements.
Okay.
And the nature of the plaque, for example, the normal vessel looks like this. If I enlarge it, the normal vessel have 3 layers. You can see the 3 layers: intima, media, adventitia. This is the normal 3 layers. But here you don't see 3 layers. This is all diseased artery. The artery is getting some sort of early blocks are coming up. In his case, the entire artery is slightly diseased. So it has a tendency to develop blocks. We want to identify a stent. We don't want to stent only that small area. We want to start from the normal segment and land up with the normal segment, so that there's a healthy entire disease area is nicely stented.
Okay.
So when we do OCT, we use that. So
another advantage of OCT.
Another advantage of OCT.
Okay.
So we can plan on the right size of the stent, land in a good area, and post stenting we can assess whether the stent is properly placed, whether there's any damage we caused anywhere at the edges.
Okay.
So for him, we also wanted to prove whether the flow is less because of the block. Block is there, we know.
Yeah.
But whether the blood flow is less or not.
Okay.
For that, we have to have functional testing, which is by like FFR. So FFR, normally if you have flow which is above 80%, we don't have to do anything. If the flow is less than 80%, we need to treat.
Okay.
And lower the flow, then it's more significant.
Okay.
For him, generally, if it is more than 80%, we don't want to do. So what we
with
do,
this case of 1.8 mm also, as a lumen, with the FFR more, you would have left it?
Yes, because FFR is ultimate, supreme. The data, the lumen small area has been correlated only with FFR, and so small lumen are significant. So because we ultimately want the flow. So suppose people can have, if it is a small area, the blood vessel is supplying a small area, even in the presence of that block, the artery will be able to supply. Whereas the artery is supplying a large area, supplying a huge heart muscle, then this block will not allow sufficient flow. So this is like anatomy, like photo. So photo, this is like really seeing measuring the blood flow, the FFR.
Correct.
So definitely FFR is the supreme. FFR has got higher scientific value and evidence. So we have to go by, but looking at his whole angio,
and that's evidence also. FFR.
The evidence also, highly evidence. Now, we have now documented that he will benefit from this procedure. We have huge evidence now. So based on the OCT alone and with the angio alone, I was quite satisfied that he would need a stent because it's a large territory. It's the beginning of the vessel, and OCT shows a very tight area of 1.82 square millimeters. Considering that generally anything above less than 2.7 is significant only. But we will, if you do an FFR, it's a matter of another 5 minutes. But we have 100% evidence that he definitely requires a stent. By chance, the FFR is above 0.8, then we have to come out without doing anything, because that we have to believe the FFR. That is the most important test. Okay, so we decided, fine, let us do the FFR, and this is the FFR what we did. See, generally the green is one pressure above, one pressure below. So we check the FFR below before giving adenosine. Adenosine is a drug given to increase the flow. So with adenosine we have to see. So the baseline is 0.9. Now we give adenosine and check. If the flow is above 0.8, we leave it. So we just did that and we reviewed again. And this is the FFR with the adenosine. So once we give adenosine, you can see the green pressure drops very much down compared to the red line, which is a difference which can say the FFR is 0.65. The 0.65 is anything below 0.8 is highly significant. Generally, 0.65 is really significant. We see sometimes 0.75, 0.79. It's all really borderline. But here, very clear cut, and it's a very strong evidence that there is a large amount of heart muscle which is not having good blood flow. So this is a 100% indication to intervene with a stent. But we have confirmed again with an FFR. We have all the evidence now. He has got angiogram. This is not clear. OCT is very clear, but the flow we didn't measure. FFR gives 100% sure. Once we decide that, then we go ahead and we stent. Using angiographic guidance. Again, I told you we had some difficulty in his hand, but we went through a 5 French guiding catheter with the backup of another guiding catheter in case of an issue. We did a left main stent. We put from left main to LAD. We put one stent. And then we repeated another OCT.
Another OCT repeated?
We keep repeating till we get a... See, the purpose of OCT is we want to also use it to see how stent result we have got. So that is a
post-stent
OCT. And because we already have a OCT with us, we use it to optimal before stenting, after stenting, until we are sure that we got the best result with stenting. Because compared to angiogram alone, if you use OCT to guide stenting, they call it as precision PCI, which means you have optimized the stenting result. Because the small things which are not seen in angiogram will be clearly seen in OCT, so that we can correct it if we find any problems there. So we did put a stent, one stent, which is 4 into 28 millimeter stent. We put it, we nicely posted. We didn't go near the edge. We did the stenting. After that we did another OCT, and this is the first OCT after the stent. So what we realized there is, the stent edges are not fully expanded. So we thought we should look at it more carefully. If you look at this is the stent which has already been done. And you can look at the stent. This stent is floating. Can you see? It's not opposed to the wall. The vessel wall is here, and this ring is a stent. Can you see that? So the round. So
it's become, what is the lumen area has come after the stent?
I will tell you. First, let's see. If you look at this part, the stent is very well opposed. You see, the stent is sticking very well. And I go to the same ostium. See, the lumen area is now in the same ostium. It is the smallest area is around 10.8. But we are not satisfied with this. Because of reasons, this is 10.8, and there is some stents which are floating at the edges. Can you see that? So at the edges, so I'll show you in another mode what we call it as rendered stent. You can see that the white color stent is good, and the red color the stent is not opposed to the wall. You can see that red color? So what we did is we put one more balloon to make the stent opposed to the wall. We made it bigger. But what then we see is very close. The edge alone we didn't go because you can hurt the normal segment here. So we didn't want to go to the edge. So we had just post dilated. But then after putting that, we again do another OCT. So this is after we post dilate. Then you see, now you see the edges are not, see the edge of the stent is looking good now. Can you see that edge is better now? You see it's more to the wall now. Can you see the stents? So this is good now. You see the lumen has become bigger. See the lumen now, where we thought it was 10, it is now 13, 12.96, nearly 13. Can you see that? The same area. And the left main is good. But if you look at the edge of the stent, we looked at, there was a small, because we posted it excessively, you look at the stent edge. I'll show it to you. See this? Can you see this? There's a small, the vessel is, that area is it's a little bit hurt, there's edge dissection. Can you see that?
There's a cut.
There's a small cut after, beyond the stent, and not the stent, after the stent. So that is why we decided that we put a small 8mm stent and cover. This is normally these are highly magnified, this OCT. If it is a small thing, we can even leave it. We have done it. But because this is a left main, we didn't want to take a chance. We put a 8mm stent there, and then we did a final post dilatation and got an excellent result.
It means it's a clear path.
It's clear path, and the area is also very nice, beautiful. And we have done a big 4.5mm balloon, nicely plastered with a big balloon, and got a great result.